think our round round. This is I think it's the fourth or the fifth one. Our honor guest is Mr. Asad Qayyum. He's one of the eminent otologists and endoscopic surgeon. He works in Peterborough, North Cambridgeshire, and he's a TBD as well, and one of the most important stone in teaching and training master classes. If you have anyone, and if you have attended the master class, you should see him. Also, I think so. You've shared the international one in the next one as well. The second one in Budapest.
That's correct. That's correct, and then in Dubai as well.
Yeah. So one of the persons that in the UK that I've contacted him, and he was replying very fast and say, yes, I'm happy to give anything for the trainees and the people who would like to progress. So thank you for accepting our the invitation, and it was very quick, to be honest. Thank you. So today we're gonna talk about the endoscopic ear surgery application and techniques. The mic's with you. Thank you.
Thank you, Mr. Ibrahim. Thank you very much for having me at the grand rounds at the 4th Lincolnshire teaching session. This is, I think, the first time I've been a part of this group, so thank you for inviting me. I understand that my audience is from far and wide, so I'll introduce myself. My name is Asad Qayyum. I'm an ENT consultant based at Peterborough City Hospital, which is in Cambridgeshire in the United Kingdom. So just for those of you who do not know where I am, the red dot here is on the map of England is where I'm based. We are about 75 miles north of London. And on the right side of the screen, this is the hospital where I work at, where all the adventurous work is carried out. And Peterborough, the city, is not a big place on the map of the UK. But one thing it's famous for is the Peterborough Cathedral, which is about 1,000 years old, and was the final resting place for Mary, Queen of Scots, and Catherine of Aragon, the first queen of first wife of Henry VIII. So yes, we have a name in history, but it's a rather bloody name, and we all work our way through to sort of improve it. So I'll talk to you briefly about myself. I trained in the east of England, or East Anglia, and that's where I started and completed my registrar training, or mid years of my training. I ended up in the Northern Territory in Australia in Darwin, and that's where I went for my first otological fellowship, and really got numbers under the belt and got my confidence up. I mean, in a year, the Darwin is famous because it has a very huge population of the Aborigines population, which is the indigenous population of Australia. And for some reasons, their skulls are very solid. So those bones are very difficult to work on. Sometimes you would go through 2, maybe even 3 burrs just to get to the antrum. And the first landmark you'll find would be the lateral semicircular canal, or the antrum. So really thick. However, they ended up with small volume cholesteatomas, but very discharging ears, and they needed a lot of exteriorization. So it was a great learning skill. And I think in a year, I must have done about 100 to 150 odd middle ears. I then came back and did a second fellowship at Addenbrooke's Hospital. And the building you can see in the background is the ENT department at the Addenbrooke's Hospital. I finally became a consultant in 2012 and moved to Peterborough in about 2014, and I've been working here since the last 9 years. If any of you recognize these names, these are the people who have worked in shaping me and turning me into an otologist. The first man here on the left is Matthew Young. I was his registrar when I was, I think, 3rd or 4th year trainee. And he said to me, "You can't do ear surgery, you have 2 left hands." I said, all right, fine. Let's see if I can do something. And then the man in the middle, Tony Narula, Professor Tony Narula, was the person who said to me that, Asad, if you enjoy otology, keep on doing it and you'll get better at it. And Gus Hunter was my mentor back in Darwin, who molded me into really improving my core skills into fine skills and turning me into a proper otologist and got a lot of numbers and confidence under my belt whilst I was in Australia. And the three guys at the bottom, late Mr. Moffat at Cambridge, Patrick Axon, and Neil Donnelly. These were the three guys who were at Addenbrooke's, more so Patrick and Neil, who really fine-tuned me into the art of otology. And there was no looking back, and I grew from strength to strength since I met with them. However, there was one thing common about the three of them, and that was they all used microscope. They were all otologists, and otologists par excellence, but they all used microscope. So my entire training was using the microscope. Now, things have evolved since I became a consultant, and things have moved on. So I never had the opportunity to work with the people who pioneered endoscopic ear surgery. And the first time, if you look at the literature, the endoscopic ear surgery came to surface around the 1970s, but it never really took off till Muaz Tarabici from Dubai in 1997 published his first case series that actually, and that was simply repairing the perforation of the eardrum. And that too was simply, he was the man who pioneered this concept that endoscope can actually be used to repair the holes in the eardrum and to look at the eardrum. And it was only after Muaz introduced and turn of the century that when the optics of the endoscopes improved, we got the high definition monitors, we got the 4K monitors, you had much more precise endoscopes, that the quality of image improved, and that led to an improved understanding of the middle ear and actually some nooks and crannies of the middle ear which were never visible before that with the microscope, and things have evolved ever since. So today what I'm going to talk to you about is why to undertake an endoscopic ear surgery, what do I do or how do I undertake my endoscope, what is my approach to endoscopic ear surgery, what procedures will qualify for endoscopic ear surgery, and in my views, what have been the pearls and pitfalls, and how all of those individuals who are here can learn on the shoulders of the first generation of endoscopic ear surgeons. And I think I belong to that first or probably 1.5, you can call it, the generation of ear surgeons, endoscopic ear surgeons. And things are only going to evolve from here. So when I talk about this topic, my audience immediately gets divided into two groups: the skeptics who do not think endoscope is the answer to the problem, and the conformists who have actually come to agree, particularly from the younger generation, that actually endoscope is the way forward. And there's a lot you can learn from the endoscopic approach to the middle ear surgery. So why to undertake an endoscopic ear surgery in the first place? Well, microscope has its limitations. So you are restricted by the narrowest segment of the ear canal, which prevents you from looking all around the eardrum, and particularly in the attic. Plus the negotiation of the speculums, and sometimes if the ear canal is narrow or whatever, you can't really put the speculum through. So if you remind yourself as to what I am saying, you can't look at the entire eardrum from the annulus to annulus or annulus to the attic in one go. And usually you would look at in 3 or 4 different angles and sort of form an image in your mind, and then use that image to think, right, what is going on and where it is going on. The other thing is that even a normal 0-degree endoscope, even though we call it a 0-degree endoscope, but it's actually divergent. So even with a 0-degree endoscope, you're able to have a circumferential look of about 25 to 30 degrees around the tip of the endoscope. And plus the endoscope is right close to the eardrum, so the view is far better and you can see the whole thing in one view. As far as the training aspect is concerned, the trainees, when you teach them with the microscope, they lack the binocular vision. So when the beam splitter is put on the microscope and you've got a teaching arm attached on one side and a camera attached on the other side, essentially the camera will see what your right eye can see if it's on the right side, and the trainee will see what your left eye can see, essentially, if the teaching arm is on the left side. So they lack the binocular vision and the depth. And also, I won't say, what I would say is the use of endoscope prevents you from doing unnecessary drilling for small volume disease, which can be easily avoided. Extensive is actually a wrong word. I would say unnecessary drilling. The benefits of, and the other benefits of the endoscope is that you have a very wide angle view and a better visualization. Now, on the right of the screen is a picture of a patient who has had an endoscopic atticotomy with a curette. So the ear canal, the attic was ending somewhere here, and this is the attic which has been removed. You can see the stapes superstructure, the promontory, the round window niche, the head of the malleus, and the facial nerve and lateral semicircular canal. The reason I'm showing this picture is because for when you start to train, or when I was starting to train, we were told that lateral semicircular canal is essentially the limit of your endoscope, and that is when you should stop. I have to admit, over the last 7 or 8 years that I've been doing an endoscopic ear surgery, I have only gone further and further and further and further beyond. And I'm now with a 30-degree scope able to take out disease which is fairly in the distance, but provided we have the correct instruments. So this is what I was talking about. This is a picture of a same patient's ear. With the speculum, you would look and say, oh, it's a normal eardrum. But when you look on the right side, when you put an endoscope in, you can see there's an attic crust, which is visible, plus the yellowish hue of middle ear effusion is far better visible compared to that with an oral speculum. My good old friend late Dave Pothier, who trained in London at the North Thames training rotation, and then went over to Canada to do a fellowship and stayed at the Toronto General Hospital and never came back, and unfortunately died a few years ago with a brain tumor. He always used to say that the learning curve of the endoscope is gradual, but once you master the skill, it is steep. And the critics of endoscopic ear surgery will say that with the microscope, you learn the skill of using the microscope and manipulating the tissues with the instrument very quickly. But if you notice, the curve of a microscope plateaus out, and once it plateaus out, it plateaus out. But once it plateaus out, that's the end of your skill set, basically. But on the other hand, it takes a very, very long time for an endoscope ear surgeon to reach the same level of skills that a microscope ear surgeon would lead, and that is where the frustration kicks in. And people stop and drop the endoscope and say, oh, it doesn't work, let's move on. On the other hand, if you look at the proponents of the endoscopic ear surgery, they talk about the benefits of the endoscopic ear surgery. And whilst the microscope's learning curve plateaus, the learning curve of the endoscope just continues to proceed and progress, and you keep on venturing further and further and further with the endoscope, because you realize how much more you can see and how much better you are in control and how much improved clearance of disease you will be able to get with it. So what are the other? So you see, globally speaking, there's the axis. As the axis is improved, so is the visualization. You're able to have. I have never ever had a problem in visualizing sinus tympani that I grew up being told that sometimes you have to drill from behind and go under the nerve, etc., etc. I've never ever had to do that, because the deepest of the sinus tympani can easily be approached with the endoscope. The access to eustachian tube and the mucosal folds in the attic have far improved. Visualization of those areas have far improved. The visualization of the entire ossicular chain in one go is far better. And just visualization of the attic adductus ad intrum, even without curating a huge amount of bone, is much better with the endoscope than actually with the use of a microscope. So this is a cadaveric picture, not mine, taken from the text of the middle ear. And as you can see in this one view, you can see the stapes superstructure, processus pyramidalis, stapedius tendon. This is actually here. This is the facial nerve. And this around here is the facial recess, which is fully open and exposed, and sinus tympani is just here underneath the pyramid. Internal carotid artery is here, exposed and visualized. The tensor tympani muscle is visible with the tensor tympani mucosal fold. Tegmen, lateral semicircular canal, and cog, which was the most difficult thing to visualize when I was training, actually was very easily visible when you use the endoscope quite regularly without any major problems. So this is a picture from an illustration from Daniel Marchioni, an article he published in the Indian Journal of Otolaryngology more than 10 years ago, and always go back to this image. One of the other things that the endoscope has improved has improved our understanding of the aeration, not only of the middle ear cleft, but how the air reaches the subscutal area or the epitympanum, and how does that air flows into the mastoid air cells. And essentially, the arrow in the red is the air channel which runs lateral to the head of the malleus, and the one in the yellow is actually that runs medial to the head of the malleus, and essentially aerates the epitympanum and further aerates into the in the mastoid. And I'll show you in the next pictures where, when you lift the eardrum, you would be able to visualize the mucosal folds. Now, when I was training, I was told whenever there's a retraction of eardrum, stick a grommet in, and that didn't sit with me well. So if there's retraction of the middle ear of the pars tensor, I can understand, okay, putting a grommet in, you'll aerate the middle ear cleft. But retraction of the pars flaccida, putting a grommet down below does not make sense. There is something going on at the top because of which this happens. The second thing is, if you notice, even if you lift the eardrum, that's with the eardrum, even if you lift the eardrum off, straight away you're able to see right from promontory and hypotympanum right up to the level of the incus and malleus head, almost you can see it. And the moment you remove the scutum laterally, we can see all the mucosal fold, the tensor tympani fold, everything becomes much better visualized to have a far greater understanding of the nature of the pathological process and the causes for that particular pathology. So if you notice, this is a patient of mine who I saw about a year ago. I operated on her, and she essentially had a retraction of the pars flaccida with erosion of the long process of incus. As you can see, that's the chorda tympani, stapedius tendon, and eroded long process of incus and retraction of the pars flaccida. And if you notice here, that's the tensor tympani muscle. And if you notice that, that's the cog. If you notice here, that's the mucosal folds you can see in the background. It's these mucosal folds which prevent the medial flow of the air behind the malleus into the medial aspect, which leads to reduced aeration and leads to long-term retraction. And essentially, if you are reconstructing the attic or if you're reconstructing the scutum, it is important that you look for the eustachian tube orifice at the top. And if you're able to identify any mucosal folds, it's important that you divide them to ensure that the mechanism of aeration of the middle ear is re-established through the eustachian tube. This leads to far better results of ossiculoplasty and pars flaccida retractions and reconstruction. There are multiple surgical benefits and anatomical benefits as well, as I've shown you in the earlier picture. The important thing is that you're able to have a far, far, far better visualization of the of various areas of the middle ear cleft. And you would remove a very limited amount of disease. You would remove a limited amount of healthy tissue, which means better patient outcomes, improved recovery, avoidance of unnecessary scars, incisions, and drilling, and less scar tissue formation, and more so preservation, improved preservation of the normal anatomical areas and boundaries of the individual. So the question I had in my mind was, when I was working with some of my trainers, I'm not going to take name, they would essentially, every patient who would come, they would do a canal wall down or a canal wall down with obliteration. And then I worked with another set of bosses, and everyone would get an athecotomy and a large cartilage, and that's it. And then I worked with the third set of consultants where everyone will get a combined approach tympanoplasty. And the question sat in my head constantly, and that was that why should I do a combined approach tympanoplasty if somebody has got a small volume epitympanic disease, which is lateral to the ossicular chain, there is no conductive hearing loss. Why should I do that? So if you've got a small volume cholesteatoma in the Prusac space, why do these patients need to have a combined approach done? A small clearance of disease from the attic. If the disease is only in the attic, then why do I need to go ahead and open the entire mastoid when all I need to do is just open up the attic? And I can do that far better through the endoscopic approach, rather than doing extensive drilling and incisions, because I'm straight looking at the disease and straight clearing the disease out. And hence, we sort of talk about this, that if you have a disease which is limited to the middle ear and the attic, the approach should be exclusively endoscopic. If it's to the attic plus antrum, depending on your skill set, you can do this with an endoscopic approach or a microscopic approach, but like an athecotomy, a small athecotomy. However, if it's beyond the lateral semicircular canal, or if it's a large volume disease, then obviously you don't have an option, but you have to drill the mastoid out. This was a paper published not too long ago, where essentially the authors did a volumetric division of the middle ear cavity on the basis of their radiological exposure. And then they looked at the visualization of the middle ear regions with different scope, or with the 0-degree scope and with the microscope. And in the first graph, first table, you can see that even with the use of a 0-degree scope, they were able to have a far better visualization. So almost a 90% visualization compared to 14% with a microscope. Sinus tympani, so eustachian tube had a 90% visualization compared to 14%. Sinus tympani had a 62% visualization compared to 24%. And supratubal area had 82% compared to 29%. Now, when the ossicles were removed, even then, the visualization did not improve significantly, particularly of the eustachian tube area and the sinus tympani. However, the supratubal recess got slight better improvement with the microscope. But if you notice, the endoscopic visualization was still almost equally good. This clearly shows that as far as visualization of the middle ear is concerned, you get far better visualization with the microscope, with the endoscope, than with the microscope under all circumstances, particularly of the hidden areas, which are important. And the reason they are important is because they play a significant role in aeration of the middle ear cleft. The additional benefits are that you have a better collaboration with your theatre team because they can see what is going on, far better video documentation, and reduce morbidity. The reason I put this picture is that if you notice at the top, my microscope is draped and ready to go at any second, but whilst I'm working with the endoscope, which means that I go in with the preparation that if I need to use the microscope straight away, I can swap, and there is no holding back or hang up. The other thing, if you notice, the chair that I'm using, it's got an arm support. So when you are using, when you're starting to do it, it's ideal to have a chair with the arm support, particularly for the arm which holds the endoscope. And that will also help in better stabilization of the hand which uses the endoscope. Now, how do I undertake the endoscopic ear surgery? So after a detailed history, a good assessment and documentation in the clinic, all my patients would get an audiogram, and radiologically, they will all get a CT scan and a diffusion-weighted MRI scan pre-operatively. By and large, I try and ensure that all my scans are routinely reviewed by the head and neck radiologist who has a specialist interest in otology. I think over the passage of time, I have learned to read these scans myself. And I would say if you want to be an otologist, you have to learn the scans yourself. You can't depend on others. Because more often than not, I would drop an email to my friend Phil, and I would say to him, Phil, I think the scan is reported by an outside source from outsourcing, and they have wrongly picked up on the diffusion-weighted MRI scan and said there is a cholesteatoma and there isn't, or it is extending, and it hasn't. And in our department, we are trying to get in the fusion images where CT and MRI can be fused, so we have a specific idea of, is the disease limited in the middle ear? If in the middle ear, whereabouts? And in the mastoid, etc. This is the radiology checklist that I always ask that should be put in the report. It hardly is, but even if it is not put in the report, these are the areas that I personally always look at on the CT scan. I look at the location of the mass, is it whereabouts it is, and how extensive it is. I also want to have an idea on the coronal images of the sinus tympani and the facial recess and their opacification. Plus, I want to see if the depth of the sinus tympani and the facial recess. I then assess if the facial canal is intact or dehiscent. You can have an idea. And if it is overhanging the suprastructure or the foot plate. Position of the jugular bulb, the internal carotid artery, it's important, and to assess whether they're dehiscent or not. Position of the sigmoid sinus. If it's a very anterior sigmoid sinus and is in complete contact with the posterior wall of the ear canal, that gives me an idea. Probably the disease is going to be small volume, but more importantly, are there any retrosigmoid air cells where cholesteatoma or opacification can extend? And if that is the case, and if I can't approach it endoscopically, it means I will be doing an inside-out drilling to go to the retrosigmoid areas. Height of the tegmen, or how low the tegmen is hanging. Is there any aeration of the petrous apex or opacification of the petrous apex, and further extension over and above and beyond the ear? Because if it is extensive, then consent has to be done appropriately, or do I need to refer the patient to a tertiary referral center? And with great humility, I would say this, that in the last 9 years that I've been working in Peterborough, I've never had to refer a single patient with cholesteatoma to Addenbrooke's Hospital, and I've dealt with all of them myself. Preparation in theatre, all these patients get a TIVA, which is total intravenous anesthesia. I tell the anesthetist the blood pressure has to be low, and I request the anesthetist to give a 1 gram tranexamic acid at induction. I would inject the ear canal with lignospan before I would put the nerve monitors on, and before I would prep the patient. And once I've done that, I used to put a Popic with 1 in 1,000. Now I just have a 1 ml or 1 in 1,000 adrenaline and just fill the ear with that while I go and drape and dress up to give as much vasoconstriction as possible. Some of my friends for the routine endoscopic ear surgery are my endoscope. I use a standard 0 and 30-degree endoscope, which were used in Fez, the 4mm ones. I do have my regular suckers. However, I use a curette quite regularly, Thomason and Hook, which help me very well, specifically for the endoscope. So I don't think you need any specialist instruments to do an endoscopic ear surgery. Really, the only two instruments which are over and above your regular instruments will be a nice sharp curette and a Thomason, which is like a whirlybird, but slightly longer, slightly sharper to cure, and so to pick up the squamous epithelium or the matrix deep down, further back into the mastoid cavity.
Yes, for sure. I agree with you. I'm sorry for the interruption.
No
It's
problem.
just, it's a half an hour, so we just get the people to rest a little bit. Yeah, I totally agree with you. I have a small set with the scope, Thomson, and the curved suction, and they call it Mr. Ibrahim's set, so they know what is it. So you can take breath and take your drink.
Any questions so far?
Anyone want to ask? He can just raise up his hand and the width of the scopes. They're asking about the width of the scope.
So the standard Fez scopes, 8 centimeters or whatever. I can't, the standard Fez scopes is what I use. Don't make them too short because then you're too close. Don't make them too long because you're too far away. So I think they're 8 centimeters, the standard length of the scope.
We for what we do, yeah, we have the standard otoscopy, but I use the pediatric sinoscopy, so it's the 16 centimeters and it's 2.9 millimeters diameter. There is the standard otology is the 8 centimeters and it's 2.7, so it's the depend. I think so Mr. Ben Amir was want to ask the question.
I'll leave my question to the last because I think there is some answering coming through as I can see through. So maybe if I have something, I'll ask at the end. Thank you very much. Thanks.
Thank you.
Okay. I can see. Can one also use the drill? Yeah,
Sorry?
asking about the using the drill while you working. So.
Yes, I have used the drill in endoscopic ear surgery, but I would never advise you to start with it. But yes, I have used the drill in endoscopic ear surgery. But that is why I'm saying that I am still growing, because that's the more recent thing I've started to do, where I've started to use the drill and open up the cavity. I wanted to put up that video and I can show you, but I haven't edited it as yet. However, I would say that's the real end of the learning curve.
I think so. We're gonna continue. We have like 3 minutes rest from half an hour, so we have another half an hour with you, Mr. Qayyum. Thank you.
Thank you. Thank you. So what condition qualify for endoscopic ear surgery, right? So for endoscopic ear surgery, I don't think I need to tell you, but literally, I think this chart or the box keeps on growing and growing and growing as your experience increases. So when I started to do endoscopic ear surgery, it was just to do an EUA and then a grommet and then perforation and cholesteatoma, ossiculoplasty, stapedectomy. Petrus apex disease can easily be approached through a subcochlear route. And I have repaired attic CSF leak, usually in the attic or in the anterior epitympanum. That's where the tegmen is quite weak, and sometimes while curetting the cholesteatoma, not curetting, but picking the matrix, you can cause a CSF leak, and that can be repaired. And middle ear tumors can be reasonably comfortably approached with the endoscope. So let's show you a video about a cholesteatoma surgery. This is where it gets interesting. You get to see some videos. So I'll talk to you through. So this is a patient who had an attic cholesteatoma. And what I've done is we've lifted the eardrum up and tried to have a look through. So you can see I would use, this is known as an NBR blade with the ophthalmologist use. It's a disposable instrument and I get some very sharp dissection with it. Divide off the adhesions. This is a second look because there is a residual cholesteatoma. You can see on the right side there's cartilage which is still intact, which was taken away. We're trying to curette out more of the attic wall because some has been left behind from the previous surgery. And if you notice, the stapes superstructure is below and intact. And whilst curetting, you've got to be very careful about it to ensure that stapes is not disturbed or it doesn't slip. So cholesteatoma you can see it is, D-knife is, I find, a very good instrument to pick up and take out the chole with the matrix. Now in this patient, the problem was the tensor tympani wasn't divided fully. And now if you notice here, in this video, at the bottom here, you can see this is the attic at the top, and this is the opening into the mastoid cavity at the bottom. And that all looks clean. There was a web here which was divided. So the aeration of the mastoid cavity is not affected and it continues unabated. Once we have cleared the disease out, then I use temporalis fascia, or not temporalis fascia, sorry, I would use the perichondrium, or I would even take the temporalis fascia and I would put it there to block off and allow the eardrum to be rested back. And sometimes I would use a simple piece of cartilage, which I would take out either from the tragus, or if needed from the Simba conchi with a separate incision. And I would, if I feel I'm not able to get the correct shape of the scutum there, I would score the cartilage and try to put a scored cartilage in there to reconstruct. Now you can see that because the patient was had a conductive loss and the depth of the stapes was low, so the cartilage was not, you could not do a tympanostapedopexy. So prosthesis was put in, and then subsequently a cartilage was allowed to, will be pushed back on it. That's the sort of a palisade cartilage which I'm going to place in there to allow, as you will see in a few seconds, to allow everything to sit back nicely. And that's the eardrum sitting back on the cartilage with the, and sometimes I would undermine a little bit of lateral skin of the ear canal so that the edges of the cartilage, the epithelium sort of grows over. You can see that, tucking it under. So the epithelium grows over the cartilage rather than trying to grow under the cartilage. You can do ossiculoplasty with the use of endoscope. This was a patient listed for stapedectomy. But when I went in, I realized that the long process of incus was eroded and not in contact with the stapes superstructure. So I managed to put a partial prosthesis on the superstructure underneath the long process of incus to ensure that we have a full sort of a contact and the complete transduction of the sound wave. And the lateral part of, and part of the prosthesis, which was sort of visible, which I was worried will be maybe under the contact of the tympanic membrane, I have covered that up with a piece of cartilage to allow there to be a cartilage cover and prevent lateralization of the prosthesis and also prevent erosion of the tympanic membrane. Once I'm sure that it is all in contact, I would then go ahead and we would place the tympanic membrane back on it to ensure that this has completely covered and closed. I usually would put a dressing, a bib dressing in the ear, which I usually take out after 3 weeks, particularly in mastoid operation in stapes surgery. I would just put some gel foam and some chloramphenicol ointment. So you can see, this was another patient. You can see how beautifully you are able to visualize the round window reflex, which you normally are not able to see that well with a microscope. And this is the beauty of having an endoscope. So if you notice round window at the bottom, the moment I bellot, you can literally see the round window movement here, and literally even the annular ligament you can see as the pressure goes on. That's the facial nerve. So I'm putting it again. Look at that. You would never be able to see, and this is the area where you would be able, if you're doing stapedectomy with this is the area where the otosclerotic plaque is best visible. And that is why when we fracture the anterior cross, you move it in that direction to ensure that there is in that direction or this way to ensure that it doesn't avulse. This is a patient with for stapedectomy. And if you notice, you'll see that. So in this patient, this was listed for stapedectomy. All my patients who have stapedectomy will also have a CT scan. So I use a laser, KTP laser. First step is to, after confirmation, is to divide the stapedius tendon. Once the stapedius tendon is divided, then I would use a laser to divide the posterior crus of the stapes superstructure. Once this has been divided, or I know we are through with this, I'll use a joint knife to separate the long process, to separate the ISJ, and then the stapes is fractured away to ensure that this is all out and comes out, and it's separate. And now I would use a laser to make a rosette shape perforation in the foot plate to allow an improved visualization, to allow an improved perforation of the foot plate so a prosthesis can be nicely placed. You can see how nicely the round window is visible underneath. That is, I think, yeah, that is a piston I've used. It's not too old a procedure. I've used this piston very recently. This is the Medell's M-Flex piston that they have recently introduced, and I think it sits very nicely. And this is all can be done endoscopically with very, very good control. Once you are able to lock it against the long process, we can use a right angle needle to push it onto the long process of incus. And once that is there, then I would move the ossicular chain to ensure that it is all fully mobile and it is working. And once I'm moving it, you can see the round window the light reflects on the round window becomes visible that it is all nicely mobile. So this was a patient who presented to me in the private practice with a conductive hearing loss and a type B tympanogram. When I first look in his ear, the picture was very much what you see here, tympanic membrane with a whitish hue behind it. And I thought he has acute otitis media with sort of pus behind it. But he told me that 3 months before that, he had a grommet, or 6 months before that, he had a grommet put in by another ENT surgeon. And he felt that there was some improvement in his hearing, and the grommet came out. He then came to see me. I took him to theater, and when I incised the tympanic membrane, I could see blood coming out. I thought, gosh, this is a jugular or something. I put some dressing and came out. Later did a CT and MRI, which showed opacification of the middle ear cleft, but wasn't sure exactly what it is. It wasn't lighting up on diffusion weighted scan, so they weren't sure what it is. So I thought, okay, well, we'll have to go in. And the histology turned out that this was a neuroendocrine tumor of the middle ear. As you can see now, I'm lifting the eardrum up, and there's nothing that you can suck out from the middle ear. So I elevate the eardrum, and I would always say that because you are doing endoscopic doesn't mean that your incision should be small or your exposure should be limited. If anything, your exposure should be as extensive as it should be, or as extensive as it can. So this was quite an extensive tumor. very difficult to remove because it was sort of slippery. So I'm trying to puncture it to see, is there pus inside it, or is this something solid? And then we realized that there was no pus in it. It was just a solid tumor. So after freeing it up from the various other structures in the middle ear, I was able to remove it and clear it out from the middle ear. As you can see in the image at the top, the long process of incus is not in contact with the superstructure. And the stapes is down there. And there is still some more tumor sitting above and around the superstructure. So this, with the endoscope, when I was doing it, you can see I'm trying to check my contact there. And I was able to remove this. As you can see, there is a fair bit of other tissue that is now coming out with the endoscope. And then close it up and went back. This patient was then, we did a histology on him, did tuberculous cultures, microbiology, everything. It turned out to be a neuroendocrine tumor. Was put through the MDT, repeated a CT scan, which showed complete clearance of the middle ear cleft with a little bit of a pacification in the epitympanum. I then went in, as advised of the MDT, opened up the entire cavity, cleared off the entire tumor, lasered the base of the tumor, and then he was having further tests done. This is quite recent. He's still being under treatment and observation, but at the moment he's stable, and there are no, he's only 24-year-old chap, and there are no other remote far disease metastasis of this disease. Rarely, very rarely it can. So if the disease is extensive and it reaches the mastoid cavity, in that case, I would open the mastoid cavity up. But in my opinion, if you open the mastoid cavity up, you should really obliterate it unless and until there is an indication to leave the cavity open. And I would use what's called a direct inject, which is this. It is essentially hydroxyapatite. So I use the cartilage to recreate the posterior canal wall. I use a superiorly based mid-temporal flap, pericranial flap, to bring the vascularity down into the attic and also help vascularity for the cartilage. And then I would also use an inferiorly based flap, which is here. You'll see me lift it up and put it into the cavity to help strengthen the reconstruction of the posterior canal wall, which I've done with the recreation of the cartilage. Once I have stabilized this area, I would then, you can see that the cavity, that's my ear canal, you can see visible, the cavity, and then I would inject, use this structure, this stuff called direct inject, which is hydroxyapatite. It mixes as it goes out, and it takes about 45 seconds, and it turns into hard bone. This is essentially used by the neurosurgeons to close the burr holes. And the beauty of this is it's like toothpaste. So it conforms to the shape of the mastoid cavity very nicely. However, the caveat is that you've got to cover it up with some form of a soft tissue to ensure that it doesn't extrurise. And then you can shape it up. You've got about 1 minute or 45 seconds to shape it up. And then you just leave it to dry. It dries up. And the osseointegration actually is absolutely beautiful without any problems. So as you can see, so this is what I would always do when I would open up the cavity. Within a few minutes, it has dried up. You can see with the frame when I'm touching it, it's taken its shape. And there it is, it's completely dried up. And now I will close it up. So this is the same mastoid obliteration, 3 weeks when I took the bib dressing out, 18 months, and then after 22 months, all well healed up, and you can hardly tell. So this is my result over the last 8 years. These numbers are actually not current, they are slightly old. But if you notice with the canal wall down, I've only done 2 without obliteration, there's no recurrence. With the canal wall down and obliteration, I had 1 patient who had recurrence, but the rest of them had no recurrence at all. And then my residual rate with the canal wall up are slightly higher than with the residual rate with the total endoscopic ear surgery. But with the total endoscopic ear surgery, this is the entire result. And as I have progressed in time and learned the skill of doing endoscopic ear surgery more, my result and clearance have improved and my residual recurrence rate is less. All my patients get a diffusion-weighted MRI scan at 12 months and at 5 years, and they're kept under observation for 5 years. And if they are free of disease at 5 years, then they are discharged. In the interim, if I feel that their hearing has dropped, then even if the MRI scan shows no disease, they would still go ahead and I would go in for a second look to understand why. In almost all of those cases, there is scarring around the prosthesis, which is fine. You can always close and come out, but that at least gives you the reassurance that there is no cholesteatoma. And usually the commonest site for residual cholesteatoma is actually mastoid, not the attic. Attic is always clean. Very rarely have I found the attic. This is the some papers from the literature where a systematic review was carried out of endoscopic versus microscopic surgery or recidivism of cholesteatoma after endoscopic treatment. And if you notice, in both these papers, one thing they have is that the residual rate are very similar to that of a combined approach, and they're not, or traditional microscopic approach, are not much different, and the complications are not much different either. So what are the initial difficulties when starting the endoscopic ear approach? Well, the two main difficulties are one hand approach and a depth perception. Those are the main difficulties that you will face or you will come across when starting the endoscopic ear surgery. How to overcome this? I'll tell you how I started. I was very fortunate because when I was doing my second fellowship at Addenbrooke's, I was taught by my trainers. They basically said, we would use or do stapedectomy and tympanoplasties using one hand, because we'll hold the speculum in the ear canal with one hand and do the entire procedure with one hand, holding the speculum with the other hand. That allowed me the versatility of using a single-handed approach or a single-handed technique. And then I was very comfortable in swapping the speculum for the microscope, and that is how I proceeded. The other thing that has helped me in my approach is that when you start operating, you can use a microscope to make your initial incision, lift your tympanomeatal flap up and onto the level of the annulus, then put some cotton soaked with adrenaline pledgets there, keep the tympanic membrane elevated, and then use the endoscope with one hand to allow you to dislodge the annulus from the groove, lift the eardrum up, and use a D knife or a drum elevator to elevate the tympanic membrane up, and so on and so forth. Start by putting a grommet in, or simple laryngoplasty is probably the way forward. What are your learning stations in your journey? Well, start by attending a course, because now there are lots of courses available. When I started it, there were no courses, and I actually just started it on my own. Start by become proficient in using 0-degree endoscope, ideally in the outpatients to visualize the ear canal. Try doing it instead of the patient sitting on a chair, try doing it with the patient lying down, so you are in the correct anatomical position when you're doing the surgery. Start by doing simple, and then slowly work on. Or the other way of doing it is that you do your post-oral approach, do your re-entry incision, put your retractors in, and then when you are doing the elevation of the tympanic membrane with the microscope, instead of microscope, do it with the endoscope. That was something I also did initially to start my journey, and then gradually moved on. And for right-hand surgeons, start by operating on the left hand. You'll be far more comfortable. What are the safety considerations? My light source is never more than 50 to 60%. All these videos that you've seen is at 50 to 60%. I use a LED light source, and if you do the endoscope, you realize you constantly keep on taking it out, putting it in, taking it out, putting it in. So light is never at one spot. Hence, there is not a huge amount of dissipation of the heat energy in the middle ear space. As I said, chair with the arm support, and my patient is always strapped to the table to ensure that the patient doesn't roll over, because very often as an otologist, you'll be telling the anesthetist, can I have the head up, head down, table to the right, table to the left, etc., etc. However, microscope should always be available, because at any minute you will drop the endoscope and go over to the microscope, either because of extension of the disease, or because of the variation in the anatomy, or because of your own experience, etc. The most important thing is, for those of you who are otologists or want to be an otologist, remember you are training to be an ear surgeon. You're not training to be an endoscopic ear surgeon. Endoscope is not a substitute to the microscope. They complement each other. You've got to be proficient in using microscope. You've got to be proficient in drilling. And I have seen with a lot of trainees when I train them, because these procedures, recordings that you've seen, part procedures been done by me, part procedures have been done by my trainees, is that the trainees try to avoid drilling, and that is not correct. You have to make sure that you don't become lazy at drilling. I was listening over the weekend to an interesting talk by the International Working Group of Endoscopic Ear Surgeons, and one thing Nirmal Patel said from Australia, the Sydney, he's the chair of the Sydney Working Group, where he said, look, if after 10 minutes I can't take the disease out, I don't dabble, I just take the microscope and get on with it. And that really is the bottom line. You know, if you can't take it out and you think you've gone to the maximum of your limit, it doesn't mean you carry on. The other thing is, just because you can see the cholesteatoma doesn't mean you will be able to take it out. You may not be able to take it out, and you will just have to swing over to the microscope, because the size of your instrument does not allow you to get down there. In conclusion, endoscopic ear surgery is challenging and the learning curve is steep. It has huge benefits and advantages over the microscopic approach. And I think the important thing is, if you haven't got the exposure, please go and work with somebody who does endoscopic ear surgery, because that is one thing that is going to help you get better and improve in time. Thank you very much.
Thank you, Asad. Thank you, everyone. I think so.
Back to you.
Can you hear me here, Asad?
Yes, now I can hear you. Thank you.
Oh, thanks for your nice presentation. And just again for the courses, I think so, Mr. Qayyum, you have you're gonna be one of the speakers, I think, in Redbridge University Hospital course, the endoscopic ear surgery.
Yes, that's tomorrow.
Yes, is it tomorrow?
Tomorrow and day after.
Yeah. So best luck for everyone. So, and we reach 40 persons. So please, everyone who have attended, please put the contact email so we can send you the CDB points. So one CDB point from the Royal College of Edinburgh. And I think so the questions is we're going to start with Mr. Benamar. He's raising up his hand.
Thank you very much, Mr. Qayyum, for this nice presentation. Interesting. Just two questions, please. Regarding the instrument and your technique itself, I can see that you have used minimal set. That's like Mr. Ibrahim said, it's really useful sometimes, and it's handy to be limiting some the instrument you are using. But is there any development in the instrument we are using? Like, is there thought about using, for example, instrument with a suction machine in it? I mean, obviously, it's always going to be the issue of two hands, one hand and two hands. I do have a set of instrument with suctions, but I can't find them still bulky, and I'm not sure. I mean, is there any more? On the other hand, do you use a holder for the endoscope?
So the first question, I don't use the instruments with suction. Spiegel produced the instruments with suction a few years ago, and I found them to be bulky or particularly with the Rosen's knife to be too delicate. You need Rosen's knife, the shaft to be nice and thick. I use a disposable Rosen's knife, which gives me a straight cut at the first incision, and then I go back to non-disposable and use it to elevate the drum. So no, I don't. I use a lot of flushing of the ear with 1 in 10,000 adrenaline, which helps me keep the bleeding to minimal. I also use the cotton wool, or the cottonoids as the Americans call it, soaked in 1 in 1,000 adrenaline, and identify the area where the bleeding is coming from and try to specifically put it on those spots, and that usually is able to stop the bleeding. So no, I do, the suction tips, I would, because they're disposable, I would use an artery clip to bend the suction tips at particular angles that I want to bend, so that I can get to the areas where I have to. So that's the answer for the first one. The second is using a holder. So no, I don't use a holder. There was a holder developed. In fact, there is a holder developed by the Boston group, which is available to buy. But they themselves say that the problem with the holder is that you have a lot of heat that reaches the middle ear because you're not moving the endoscope in and out. It's focused at one particular, so the heat trauma, thermal trauma is high. The second thing is, if during your surgery, if the patient goes light and moves, the trauma and the damage will be far more because you've got a stable endoscope which you can't immediately move away. So those are the reasons why the proponents of holders have actually now moved away from advocating the use of a holder.
Thank you. Sorry, just another point about your nice case of obliterations. You mentioned that you put the hydroxyapatite and then you cover with the 2 flaps you created. I didn't catch that. Did you put the flaps first and then you put the hydroxyapatite above, or?
No. So what I do is, the first thing I do is I would use the cartilage to recreate the posterior canal wall.
Yeah.
And then once I've recreated the cartilage to create the posterior canal wall, then I swing the superior and inferiorly based flaps in to bring superiorly based flap goes down to the level of the attic. And that actually allows the nutrition or the oxygenation or vascularization to diffuse through to the cartilage. It's a pericranial flap, not a muscular flap. And then I use an inferiorly based flap to bring up from the bottom, again to support the lower part of the cartilage. Then you have a cavity left at the back behind the muscle flap, and that cavity is filled by hydroxyapatite. And then cover it up with the muscle. So the important thing here is that when I'm doing this, I always assess and see how big a cavity I have. If it's a small cavity, then I would not use a pericranial flap. Then I would just use a temporalis flap because the bulk of the temporalis muscle is good enough to block the cavity off with the cartilage. If I have a large cavity, then I would use cartilage, pericranium, and hydroxyapatite to block it all off.
Thank you very much. Thank you. Very nice. Thank you. Useful. Thank you.
Thank you, Mr. Kim. Thank you, Mr. Ben. Anyone else want to ask a question? So, I think no questions. Second is for the low economic countries, we have to invest a huge amount in buying endoscopy and microscopes. Understandable, but you can't have much, to be honest. But by the way, the endoscope is much cheaper than the microscope, and you can do a lot of things with it as well. I think so.
So for the low income country, look, I go back to my statement of it's not a substitute to using a microscope. Now, for the low income country, I mean, I'm originally from Pakistan, so I know the dynamics of a country with low socioeconomic status. And I know the country where I hail from, there is a problem of, if you tell a patient you may need two set of surgeries, so you may require a second look operation. That's not looked upon very favorably. The second thing is there is no guarantee. It's not like the National Health Service in the UK. So there is no guarantee that the patient is going to come back to you after you've done the operation. There's a very high possibility the patients will be lost. In these group of patients, you have to decide that you have to give one operation, which is going to be your penultimate operation, and that has to be the one in which you are most proficient in dealing with, whatever that might be. And in those cases, yes, endoscopic ear surgery is a skill that you should have, but it should not be the first operation that you would propose, because even though I'm very confident with my endoscopic ear surgery, etc., and I've been doing it for 9 years, but when it comes to that group of patients, even I would not be advocating or advising them to do the endoscopic ear surgery only. Yes, I would, for my skill set, I would start the operation with an endoscope like I start for every middle ear operation. But then if I have to swing over to the microscope without any hesitation, I will swing to microscope and I will use that.
I think so. No more questions. Is there any solution for this situation? Yeah, I think so.
There is one hand that has been raised.
Okay. Yeah, I'm just looking to the chat. Yeah, Mr. Dayemi, yeah.
Thank you very much for your talk. I just want to find out if you have any contraindications to endoscopic ear surgery. So if somebody has had surgery and let's say revision, or are there any cases that ab initio you will not consider endoscopic ear surgery? Thank you.
It's a very good question. So second look operation or revision surgery is definitely not a contraindication. That I would not accept as a contraindication. Yes, if it's a very narrow auditory canal or very narrow meatus, which prevents me from putting my scope in and also putting my instruments and suction in, and the chances of traumatizing the ear canal are higher, or I can't negotiate easily with the instrument, that will be essentially a contraindication to endoscopic ear surgery. But to be honest, I would be able to decide that in the outpatient clinic without actually having to make it to the operating room.
Totally agree with you. You have to prepare yourself for all scenarios. So just prep the microscope, put it on the side, and then started your operation with endoscopy. If you want to convert it, you can convert it. So I think it's just a matter of what is the condition and what you're gonna find. Even the pre-scans is not really. They are helpful to know or predict what's there, but not telling you what exactly there.
I agree with you. I mean, and COVID has been the biggest testament of that we've done scans of patients pre-COVID and they've been coming in for surgery post-COVID. So that's not surprising.
Thank you, everyone. We took 1 hour and 8 minutes, so this is good. Thanks, we're on time. Make sure everyone puts his name, place on the chat so we can send him the certificates. The second thing, there is a free endoscopic ear surgery anatomy book. I have just made it. It's simple, and it's free online. So anyone who wants it to get it, it's just I can redistribute it again. I know that I'm not talking only to the 40 persons who have attended today on time, but I know that there will be also many of you there watching this online later. So you can contact me over the email that's in the YouTube channel. And again, thank you, Mr. Qayyum. This is really amazing and opportunity to us to learn from you and to hear your experience. And that's it for today. Thank you.
Thank you so much. I'm really grateful, Mr. Ibrahim, and I'm grateful to the audience for putting up for so long. Somebody has asked me, do I have a regular YouTube channel? I don't have a regular YouTube channel. I'm not I don't get time to get things onto YouTube, but I do go around and speak. So for all of you who are here, I would definitely say come and attend masterclass. They do have some great, it's a great platform to learn.
Sure.
They go around the world and it's free at the point of delivery. And masterclass has their online presence, a huge online footprint, and you can listen to all the previous lectures, and they've got a cyber textbook there for all the fun and fantastic surgeries from some of the doyens from around the world. I'm not there, but some of the bigger names are there.
You're the one of them. Thank you, everyone.
Very much.
Thanks.
Take care. All the best. Nice to see you all. Take care. Thank you.
Thanks.
Bye-bye.
Bye.
Thank you very much.